and welcome. This is ACARE LevelUp Series 9, and this webinar is dealing with comorbidities in HAE, including risk of thrombosis and autoimmunity. My name is Dr. Thomas Buttgereit, and I'm a physician at the ACARE Berlin, the Angioedema Center of Reference and Excellence Institute of Allergy. And here with me is an esteemed faculty with Dr. Andrea Zanichelli from the University of Milano. Hi, Andrea. And we also have Linda here, Linda Sundler Björkman. She's from the Lund University in Sweden. And also it's my special pleasure to welcome Assistant Professor Dr. Stephen Grover from the UNC Blood Research Center at North Carolina at Chapel Hill University in the US. Hi, team. I'm really happy to moderate this Series 9 webinar. So the aim of this webinar is actually to understand and learn more about comorbidities which may be associated with hereditary angioedema. So we will look at the current results from surveys and also disease registries, and we'll discuss and present the data. And particularly, we are more interested in to understand how there could be a higher risk of thrombotic events in HAE patients and how could this be explained. So we have prepared a very nice agenda for you. Andrea will start. But before this, let's look at our registration. So you can see here 196 people from all over the world have registered, and you see here 56 centers and countries are involved. Yeah, from all over the world: North America, South America, Africa, Europe. I see Asia. Welcome. Thank you for joining. So please also keep in mind this webinar is CME accredited. So in the end, you receive 1 CME credit point for this. And for getting this, please keep in mind that you can complete and should complete a survey at the end of this webinar. This is actually the link for this in the end to receive also the CME point. And what is specifically important is that you are invited to ask questions, to make comments in the Q&A box, and we will be happy to discuss your questions. So this is actually our program. And there's also going to be a next webinar, just to highlight this year. This will be on the September 24th, and the topic will be advancing treatment options in HAE, new frontiers in oral on-demand therapy. So do not forget to sign in, and also do not forget to stay connected with us, with ACARE on social media and websites. And you can also subscribe and our newsletter to be always updated. So I think it's now time to hand over to our first speaker, Andrea. We are really looking forward to your talk. So take it away, Andrea.
Hi, Thomas. Hello, everybody. Thank you for the nice introduction. I'm very excited to take part to this webinar. So I will start sharing my slides. And so I will speak about comorbidities in C1 inhibitor deficiency. I will discuss with you the results from an Italian survey. So this is my disclosure. So as we all know, angioedema due to C1 inhibitor deficiency is characterized by a recurrent unpredictable episode of swelling, and that can affect the skin, as you can see here, hand, feet, the face, and also the gastrointestinal tract, and causing abdominal pain, and of course the larynx, and this is the life-threatening attacks that need to be recognized and treated promptly. Yes. So what happened during an attack of angioedema? Because there is a deficiency of the C1 inhibitor in the blood of a patient, there is an excessive production of bradykinin during an attack, as you can see here, the swollen hand. And bradykinin binds to its receptor on the endothelial cells, and there is then an increase of vascular permeability and angioedema formation. And bradykinin is generated by the activation of the contact system, so from factor 12, activated factor 12, that in turn activates the kallikrein-kinin system. So there is an activation of kallikrein that the high molecular weight with the release generation of bradykinin that then binds to its receptors. And these systems are regulated by C1 inhibitor, as you can see in this picture. And yeah, this is a bit a vintage slide from more than 10 years ago, and that was drawn by Marco Ciccardi, but I think it's still summarize all the activities of this serine protease, the C1 inhibitor, that is, of course, the inhibitor, as we saw, of the contact kallikrein-kinin system, but it's also, of course, the inhibitor of the complement system, and that's why it is called C1 inhibitor, because it was discovered at the beginning when it was discovered. It was discovered for its inhibition on C1, and also later on it was found that it also works inhibiting MASP1 and 2, and also is also involved in coagulation, because it inhibits factor 12, factor 9, and thrombin, and also in fibrinolysis because it inhibits plasmin. And in this study, we wanted to investigate the presence of comorbidities in a patient with C1 inhibitor deficiency, because C1 inhibitor is involved in all these pathways. No? So we thought maybe the deficiency of this serine protease might cause pathological consequences, not only angioedema. And then we wanted to compare the presence of these comorbidities to the general population, and also we wanted to assess the effect of long-term prophylaxis with androgen and tranexamic acid on the incidence of comorbidities in patients with C1 inhibitor deficiency. So we did a retrospective cohort study. We enrolled adult patients with angioedema due to C1 inhibitor deficiency, so hereditary and acquired angioedema, and they were referring to our Italian networks of centers for angioedema, Ithaca, in the period from 1979 to 2021. So the new modern LTP, long-term prophylaxis, we start prescribing this new modern prophylaxis only in 2020 in Italy. So until that time, we only had androgens, tranexamic acid, and eventually plasma-derived C1 inhibitor for intravenous infusion. So the prevalence of comorbidities, regarding the prevalence of comorbidities, we compare angioedema patient with general population, and we did a qualitative comparison. And then regarding the incidence of comorbidities, we compare patient, as I said, on long-term prophylaxis with the androgens or tranexamic acid with patients that were not on long-term prophylaxis. And we did some comparison with the logistic regression, odd ratio, and possible scenario analysis. These were the comorbidities that we took into consideration. So the frequent more frequent comorbidities: hypertension, hypercholesteremia, diabetes, heart disease, cancer, cerebrovascular pathologies, and also we consider appendectomy, because several patients undergo appendectomy, miscarriage, psychiatric pathologies, pathologies of the thyroid glands and hyperthyroidism, hypothyroidism, autoimmune disease, and renal disease, and also liver disease such as liver neoplasma and infection from HBV and HCV. So we compared the data from the general population. We took the data from our Statistic Institute, National Statistic Institute, or from a database from other database of some societies. And so what we found, we studied 500 patients, and the mean age was 53, and we also checked the smoke use and alcohol use, and we also had 10% of patients that had acquired angioedema. And this is a curious data, so we also check how many patients had a laryngeal attack, and we found out that in our population, at least 1/3 of patients had experienced a laryngeal attack. So regarding the comorbidity prevalence, we find out that there was no really difference between hypertension in our study cohort and in the general population. Also regarding hypercholesterolemia, there was no difference, but there was a statistical difference regarding heart disease and in particular acute myocardial infarction. And actually, we checked if there was an influence from the age, but the distribution according to age is quite similar between angioedema population and general population. Then we checked if there was this data could be influenced by the body weight, but also the general population is comparable, the patients are comparable with general population in terms of body weight. And also we checked the smoke habits, and we also find that the data are comparable also in terms of smoke habits. So actually we concluded that this difference does not depend on age, sex, body weight, smoking habits, but might depend on the activation of the coagulation system, since, as I show, C1 inhibitor control also the intrinsic coagulation pathway. But I think this will be then Linda will go more in details on this in her presentation. So we also checked other comorbidities as diabetes, renal disease, and we didn't find statistical differences. We found an important statistical difference in appendectomy. So only 1% of the general population undergo appendectomy, and 60% of patients with angioedema with C1 inhibitors undergo appendectomy, and this is because of the abdominal attack that usually that might misdiagnose for an acute abdomen. And also regarding cancer, we didn't find really differences. We find differences between virus C infection, and this is due to the use of plasma-derived C1 inhibitor that were not pasteurized before 2004. So since 2004, in Italy, we also used the plasma derived from CSL that is pasteurized, and now they're also microfiltrated. But before we used different plasma derived, and there were some cases of infection. And of course, regarding the patient with acquired angioedema, we found a great difference in the presence of monoclonal gammopathy and lymphoproliferative disorder. So when we check patient on long-term prophylaxis, as you can see, almost half of the patients were on long-term prophylaxis, and they were mostly using androgens. And so we compare patient on prophylaxis with androgens and patient without prophylaxis with androgens. Most of the patients were female, and we know that the disease is more severe in female patient. And also there was a greater proportion of overweight and obese patient that were using androgens, and this might be an adverse event of androgens. So we check the incidence of disease such as hypertension, and when we analyzed the incidence, we consider, as I said, the odd ratio, and you can see if the odd ratio is more than 1, then prophylaxis is a risk factor. If odd ratio is less than 1, then prophylaxis is a protective factor. And as you can see, regarding the incidence of hypertension, there is prophylaxis with androgens is a risk factor, and also prophylaxis with androgens is a risk factor for hypercholesterolemia incidence and for diabetes incidence. And of course, we all know that androgens can cause a liver lesion such as angioma or focal nodular hyperplasia, and you can see that the odds ratio is 8 and 6.9. So prophylaxis with androgens is certainly a risk factor. Regarding other comorbidities such as cancer, we only analyzed 7 patients, and we couldn't really determine if the comorbidity occurred after at least 1 year of therapy with androgens or during the first year of prophylaxis. Sorry. So we hypothesized 2 scenarios. So one scenario is where the cancer, the patient reported cancer the same year they started androgens, so probability is 0. And but then another scenario is that a patient reported cancer after all patient reported cancer after 1 year of therapy with androgens, and you can see that the odd ratio is very different, and seems that prophylaxis might be a risk factor. So this is still something that we have to investigate better to better understand if actually androgens might be a risk factor also for cancer. So in conclusion, compared to general population, we found an increased prevalence in patients with C1 inhibitor deficiency for appendectomy, heart disease, acute myocardial infarction, and virus C infection, hepatic virus C infection. And when we compare patient not on long-term prophylaxis with patient on long-term prophylaxis with androgens, we found an increased incidence for hypertension, hypercholesterolemia, diabetes, focal nodular angioma, and hepatic angioma. No association between tranexamic acid and any comorbidity was found. Only one deep venous vein thrombosis was reported from one patient with acquired angioedema that was on tranexamic, but this patient has been taken tranexamic acid for 19 years and then reported deep vein thrombosis, so we don't know if it's really associated with tranexamic acid. So I think the most important conclusion is that these results warrant an extensive workup for comorbidities in patients with angioedema due to C1 inhibitor deficiency, in particular in those patients exposed to long-term prophylaxis with androgens. And I thank you for your attention, and I give it to you, Thomas.
Thank you very much, Andrea. Very interesting results, and I saw it's published last year, so very recently published. Very interesting findings. So I see no questions for the moment in our Q&A section, but I have a question for you, Andrea. So you found heart diseases and risk of myocardial infarction, right, as one of the risk factors. So did you also check for androgen exposure, so that this could be also linked to treatment?
Yeah. I mean, we find out that there was an increased risk increased risk and increased incidence of hypertension, and actually, for heart disease, we check more hypertension, diabetes. Yeah, we have to check also for heart disease. I don't think we found it, but I can see if I have an answer for you.
And maybe one more question: how how important do you see the multidisciplinary approach to HAE patients when you see in these comorbidities you found like heart disease, myocardial infarction risk, and other comorbidities? Anything you take with you for your practical approaches in managing these patients with HAE?
No, yeah, I think we should focus on comorbidities. Consider that this patient might also have some other comorbidities related to C1 inhibitor deficiency. We know that angioedema, when it is resolved, there is a restitutio ad integrum, so there are no reliquates, and but maybe the deficit of the deficiency of C1 inhibitor might be involved in other comorbidities. So we have to investigate this, and in particular, patient that were on androgens, they need to be. We need to do a workup for comorbidities in this patient.
And final question, Ankur raised this question. So do you think there is a risk for diabetes due to androgen use?
Yeah, there is an increased risk for diabetes that was not found in general population compared to general population, but in patients that were on androgens, we found an increased risk for diabetes in patient on androgens. So, and also with hypercholesterolemia. So,
okay, thank you. So thank you, Andrea. I think it's now time to move on with Linda. So thank you very much. And now we are curious about your talk.
Yes, thank you for inviting me. And I'm very happy to be here and talk about comorbidities in hereditary angioedema. And my name is Linda Sundler Björkman. I'm a physician specialized in allergy, and I work in Lund in the south of Sweden, also with HAE patients. So I'm going to talk about the power of diseased registry and what the Swedish HAE registry tells us about comorbidities. So rare diseases like hereditary angioedema affect a small number of patients, which makes it difficult to find comorbidities. So patient registries are valuable tools to collect sufficient data in order to reach significance in comorbidities in rare diseases. And it's very important also to compare the cohort of the disease patients with matched controls from the background population. And also, of course, the quality of the registers are very important. So in Sweden, we have a lot of registers, and they are held by the National Board of Health and Welfare. And we have a lot of health data registers, for example, Swedish Inpatient Registry, which registers all diagnoses when you are at the hospital and also at the outward clinics. And then we have the cause of death registry, cancer registry, prescribed drug, and medical birth registries. We have also a lot of other registers like social services and financial aid and so on. So all Swedish citizens are automatically registered in different registers. And they are, of course, protected by absolute secrecy. As I said, it's important that the registers are of good quality, in which there are studies showing that the health data registers are of high quality, with a high coverage with above 99%, and also with a valid diagnosis. So the question is, this webinar is about hereditary angioedema due to C1 inhibitor deficiency and comorbidities. And why is that? So as Dr. Zanichelli told us, he had a similar picture of this. So C1 inhibitor is a regulator in different systems in the body. And for example, as he said, also the complement system and the intrinsic coagulation system, the kallikrein-kinin system, and the fibrinolytic system. And we all know what happens within the kallikrein-kinin system. So the bradykinin is produced increasingly, and which lead to vascular permeability and angioedema, which is the most obvious and primary symptom with HAE. But what about the other systems? Could that lead to some symptoms or even diseases? So the research question when I did my PhD about HAE and comorbidities was, does HAE with C1 inhibitor deficiency modify the risk of contracting other diseases? So during my PhD, we did a case control study comparing patients with HAE with C1 inhibitor deficiency and matched controls. And we measured and compared these two cohorts with Swedish registers. So we had a cohort consisting of 239 HAE patients, or we didn't have it, but I found out all about these patients, tried to collect basically the total national cohort of HAE patients. And then through Statistics Sweden, we identified 10 controls per patient from the National Population Register. And these individuals are matched for regarding gender, age, and county of residence in Sweden. And what did we find? Well, we could see this in the HAE patients that they about 90% had type 1 and about 10% had type 2, and it was almost equal female and male, a little bit more female. And the results when we compared registers were, we found a significant higher prevalence of autoimmune diseases within the HAE cohort. And we know that there has been case reports about autoimmune diseases within HAE. So it wasn't maybe a total new thing, but at least it was interesting. So we could, when we looked during for the subgroups of autoimmune diseases, we could see that it was about the autoimmune diseases that affect the endocrine system, like diabetes type 1, and also hypothyreosis. And also, we saw that there was a significant increase in autoimmune diseases affecting connective tissue, like lupus. And when we have all these registers, we can also kind of confirm the findings with other registers. So we confirmed the hypothyreosis finding with also a higher prescription of thyroid hormone in the HAE cohort, as you see. And another interesting thing that we found was we looked at cardiovascular diseases, and that was significantly higher prevalence in the HAE group, and especially arterial thrombosis, hypertension, and venous thrombosis. And so the conclusions from the comorbidity study is that HAE patients with C1 inhibitor deficiency patients have a higher risk of contracting autoimmune diseases, especially SLE, and diseases affecting the endocrine system. They have also a higher risk of cardiovascular diseases, especially VTE. Also, we found a higher risk of hyperlipidemia and a higher risk of allergy and asthma, but we did not find an increased risk of cancer in this study. And yeah, this is, of course, Swedish patients we're talking about. So when we published that, I was contacted by Stephen Grover, who is the next speaker. And we did a sub-analysis with this study, and we can then show that there was a significantly increased risk of VTE in the HAE C1 inhibitor patients compared to controls, which is very interesting. And here is also the cumulative incidence of VTE in the HAE group versus the controls. In another study, we combined registers with we combined the health registers with the Swedish multi-generation register to determine if individuals with HAE have an increased risk of VTE compared to family members without HAE. And this is the characteristics of the study population. So we had, all in all, 2,006 individuals, of which 365 had HAE. And the non-HAE individuals are first-grade relatives, like siblings, parents, and spouses. So all of these 2,006 individuals, 103 got VTE. And of these 103, 35 had HAE, which means that, there was a higher prevalence in the HAE group versus the non-HAE family members. So we also did did this study where we adjust, or this is the same study, but we adjusted for different things. So we adjusted for a lot of things, like sex, education, birth year, country of birth, and also several diseases. And when we did all these adjustments, we could still see an odds ratio of 2.7 with the risk of VTE in HAE patients. We also looked at the age, and the HAE patients were significantly younger when they got their first VTE compared to the non-HAE individuals. So the mean age in the HAE group was 51, compared to 63 in the non-HAE group. And here is just a diagram showing the age onset of VTE. So you can see the red, the red graph is the HAE patients, and the blue ones are their relatives. So you can see that they get VTE earlier in life. So in summary, to summarize my talk, patient registries are very valuable tools, especially, I would say, in rare diseases where it's hard to find large cohorts. The drawback is that we didn't have access to medical records in this study. But an advantage, I would say, is that it's very objective data. It doesn't depend on what people remember or no recall bias. It's very, very objective. There could be a potential selection bias since HAE patients come to the hospital every year, and maybe they are more medically examined. So that could be something. A good thing with registers is that we could follow up comorbidities over time and investigate potential effects of different long-term prophylaxis. So we could see now when this study was done, a lot of patients were on androgens and tranexamic acid. Now we have another spectrum of medication, which might affect the possibility to receive other comorbidities. So it will be interesting to follow up in a few years. And there will also, of course, clinical studies are needed. We need information about medical circumstances, why things happen, and what, and so on. So that's, of course, as a complement, and I also work with that now. We also need preclinical studies when we see something like this, comorbidities, we need preclinical studies to look for the mechanism behind it and to find out why exactly is it like this. Does it depend on the disease activity, or does it depend on the long-term prophylaxis or the lack of long-term prophylaxis? I mean, if you have a disease, active disease, you need long-term prophylaxis. Otherwise, you wouldn't need it. So what is what in this? So yeah, thank you so much. And this is just acknowledgements for those who helped with the studies.
Mm-hmm. Thank you very much, Linda. Very interesting data you presented, and also very recent data you published. I think we will come later to the discussion on risk of thromboembolism, as our colleague Stephen Grover will expand a bit more on this. So I would actually be interested in hypotheses how there could be an increased risk for autoimmune diseases, for example, SLE, what you have shown. So is it is HAE an autoimmune disease as well, or is it it's some complement? The complement system is involved, but how does this connection association could be theoretically explained? This is something I'm interested in.
Yes, I think it has to do with the complement system. It's activated all the time. So maybe when it's really needed, there's not enough of complement fragments to collect the dead cells or things, and that's how cells show their DNA, and that's how auto antibodies are made. So I think it has to do with the complement system side of the interaction of C1 inhibitor with the complement system. And if you don't have C1 inhibitor, the complement system is overactivated all the time, which could lead to a lack when it's really needed, I guess. That's a hypothesis. I'm working on it right now.
Very interesting. So Anko from India also has a question. So he thanks you very much for this useful data you presented. So he found that there are some HAE patients that have high IgE. So did you also check for other allergic conditions like asthma, allergy, urticaria, so that there is maybe some connections with this?
We looked for allergy and asthma, and it was both of them were higher prevalence in the HAE group. Yes, so that could. They come to our allergy clinic when they are. We control them every year. So that could be that we ask them, do you have asthma? Or maybe they say something and they get an examination to show that they have asthma or allergy. So, but otherwise, it might also be true. And I'm actually going on to look at the IG, different categories of IgGs and IgE, to see if they actually produce more of these immunoglobulins. Maybe that could be so. But we actually found that they have a high risk of allergy, and it's very, very interesting. And I have more preliminary data also with the blood tests taken in the patient that I can show later on.
Thank you. Maybe final question. Mares Fisse has a question about cerebral thrombosis. Did any of you, Linda or Stephen or Andrea, have some experience with this? Did any patients of you had this type of thrombosis, cerebral thrombosis? Have you seen this?
I have not seen it in my patient. So no.
Okay. So I think this is the perfect bridge now to come to the last talk of this Series 9 Level Up. So I'm happy to hand over to Stephen, who will talk about HAE and thromboembolism. And is there a link, and why could there be a link? So Stephen, take it.
Perfect. Yes, thank you very much for the introduction and the opportunity to present to you today on this really important topic. My name is Stephen Grover. I'm a research assistant professor at UNC Chapel Hill. And today I'm going to talk to you about HAE and thromboembolism. Is there a link, and why? These are my disclosures. And I think just some important background on venous thromboembolism. So this is a cluster of diseases that includes both deep vein thrombosis and pulmonary embolism. It has an incidence of about 1 in 1,000 per year in the general population, and it's a significant source of morbidity and mortality. And importantly, up to 40% of VTE events lack a clear underlying provoking factor from the known risk factors that have historically been considered. Some statistics about VTE here, focusing on the US. It's a major health burden. So blood clots affect approximately 900,000 people each year. And in 3 of 10 individuals who have a blood clot, they will experience another episode within 10 years. And unfortunately, 100,000 people per year die of complications of VTE. And this can be sudden in patients who suffer from pulmonary embolism, with 1 in 4 people dying. It's a large health cost associated with VTE and its management. So in the US, it costs approximately $10 billion per year, and per patient, this is roughly 15 to 20,000. And it's important to mention that blood clots can really happen to anyone, and they are often preventable, and early diagnosis is really critical. So when thinking about venous thromboembolism, there's a really close connection with the coagulation system. So impaired regulation of coagulation is a very established driver of VTE risk in humans. And here I'm just listing some of the classical VTE risk factors that we know of, things like factor V Leiden, prothrombin, gene mutation, protein S and protein C deficiency, alongside antithrombin deficiency. And these last three are all deficiencies in endogenous anticoagulants. And so a question that we've asked is, might C1 inhibitor deficiency behave similarly? And from this perspective, it's really important to put C1 inhibitor in its context within the coagulation system. So here you can see the classical coagulation cascade, this waterfall system, which includes the extrinsic pathway, the damage pathway here on the right-hand side, as well as the contact or intrinsic pathway here on the left. That includes autoactivation of factor 12 that leads to stepwise generation of further coagulation proteases and eventually the terminal coagulation protease thrombin. And within this context, C1 inhibitor sits at a really important position, serving as the major endogenous negative regulator of plasma kallikrein, as we know from its activity in the setting of HAE with liberation of bradykinin from high molecular weight kininogen, but it's also a critical negative regulator of factor 12A and factor 11A, and so really acts to suppress the contact pathway of coagulation. And obviously in patients with hereditary angioedema, they are lacking this important endogenous anticoagulant. And when thinking about coagulation in the setting of HAE, there is evidence that patients with HAE have a procoagulant state. And this has been seen with respect to increasing markers of activation of coagulation, including prothrombin fragments, thrombin-antithrombin complexes, D-dimer, as well as shortened activated partial thromboplastin time assays. And these markers are elevated or abnormal at baseline, and they're further enhanced during attacks. But in this context, HAE has not classically been associated with venous thromboembolism, as I'm sure many here will appreciate from their training. We have looked a little bit further at the interaction between C1 inhibitor deficiency and activation of coagulation, here using a very sensitive assay looking at contact pathway initiated thrombin generation, and we found that this was significantly enhanced with patients with C1 inhibitor deficiency associated HAE. So in this series of graphs, I'm showing you real-time thrombin generation in samples from either age and sex matched controls or in samples from patients with HAE with different levels of residual C1 inhibitor activity. So pink is greater than 25% residual activity, and the darker red is less than 25% activity. And in these curves, you can appreciate that compared to the gray curve, there's a significant increase in thrombin generation in both subsets of HAE patients. And when we quantify this as parameters such as the time to thrombin generation or lag time, or the maximal amount of thrombin generation, the peak, we can see that this is significantly elevated selectively in that cohort of patients with less than 25% of residual activity, here further supporting a procoagulant state in patients with HAE. And this link between HAE and VTE really came onto the scene through the work that Dr. Sundler Björkman introduced just earlier in her study evaluating comorbidities in hereditary angioedema, published back in 2022. And what was really interesting from my perspective as more of a coagulation biologist was this really interesting signal for an increased risk of venous thromboembolism in patients with HAE. And in the sub-analysis that Dr. Sundler Björkman mentioned, we pulled out both venous and arterial thromboembolic events, so VTE including DVT&P, and arterial thromboembolism, thinking of myocardial infarction, ischemic stroke, and peripheral artery disease. And here you can see cumulative incidence curves. And what I'd like you to sort of appreciate from these curves is that in the HAE cases in orange, it appears that the incidence lines deviate in these cases with apparent increased incidence of VTE in the HAE cases, but this does not appear to be the case for ATE in the curves on the right. So to summarize the two studies that Dr. Sundler Björkman introduced, which were based on this pair of Swedish case control studies, these were obviously matched with appropriate controls. And if we look here at these forest plots, considering the odds ratios of VTE associated with an HAE diagnosis, you can see this right shift indicating an increased risk that was significant in both studies, with odds ratios ranging from 3.59 in unadjusted analyses to 2.7 in fully adjusted analyses of this second paper. And these were published fairly recently. And I think this nicely demonstrates the association between HAE and a potential increased risk of VTE, at least in the Swedish population. And so something that we've looked to do, taking this forward, is now move over to a UK-based population. So here we're leveraging data from the Clinical Practice Research Data Link in the United Kingdom. And this provides us with access to the healthcare records of approximately 60 million individuals in the UK. Here we identified HAE cases based on diagnostic coding and prescribing information and matched to a control cohort. And we then looked at the risk associated with an HAE diagnosis of selectively VTE. And here you can see, again, here using hazard ratios, that an HAE diagnosis was associated with a significantly increased risk of VTE, with odds ratios that were quite similar to the previous Swedish-based studies of 2.63. So here in an independent study population, we found a similar phenotype. And I think it's important to ask, why has this phenotype not been apparent before, and why is it not considered a typical presentation of HAE? And of course, as needs no comment to this audience, swelling attacks are the primary presentation of HAE, and quite rightly the focus of patient management. The increased risk of VTE associated with HAE is considered mild to moderate. The risk estimates are approximately 2 to 3-fold increased risk. And so it's unlikely to be apparent in individual physician-based practice. And these studies really require well-powered registry and population-based approaches to identify novel associations. I think it's also important to consider potential confounding in these studies. There's obviously medication-based confounding. C1 inhibitor replacement was proposed. However, in the setting of HAE, it's not associated with an increased risk of VTE. Actually, the work of Dr. Farkas has shown, if anything, it looks to be protective against VTE. Tranexamic acid has also been proposed. However, we know in several independent study populations, TXA is not associated with an increased risk of VTE. However, for attenuated androgens, there is supporting evidence that perhaps this can contribute to VTE risk, as well as the potential for indwelling catheters to also enhance VTE. And there's again supporting evidence of this. However, I'd highlight that in our studies, VTE risk remains even when excluding patients receiving long-term prophylaxis that would include several of these drugs with putative links. The other potential confounding is medical attention-based. It's certainly possible that there's greater interaction of these patients with the medical system, and this could act as a potential confounder. And so we've taken some steps to try and address this, changing from an hereditary angioedema-based approach to a human genetics approach focused on the gene that underlies C1 inhibitor deficiency, SERPING1. So here, using large population-based biobanks with genetic information, namely the UK Biobank and all of us in the United States, we've identified individuals with rare predicted loss of function mutations in the SERPING1 gene from approximately 650,000 participants using in silico functional impact scoring. So here I'm providing a lollipop of all the mutations that we identified in this general population-based study. In red, you can see high confidence loss of function variants. These are frame shifts, premature stop mutations, and other significantly impactful variants. And yellow is a single amino acid substitutions predicted to have significant impacts on function. And when we look at plasma samples from patients, or individuals rather, carrying these predicted loss of function variants, we can see that compared to wild type non-variant carrying controls, these individuals have significantly lower levels of C1 inhibitor antigen. And although they may not present or have a diagnosis of HAE, they do have lower C1 inhibitor levels. We then looked at the relative incidence of these SERPING1 predicted loss of function variant carriers in VTE cases in this study population versus non-VTE controls. And here you can see, again, forest plots looking at analysis of the individual data sets as well as a meta-analysis of the two. And what we saw here was that patients with, or individuals with predicted loss of function variants in SERPING1 were oversampled in the VTE cases compared to the controls. And this results in a hazard ratio of approximately 4.6, indicating that the variant carriers have a significantly increased risk of VTE. We've also sought to separate the impact of C1 inhibitor deficiency by using preclinical studies, here specifically focusing on C1 inhibitor deficient mice that have previously been shown to model key aspects of hereditary angioedema, including having enhanced vascular permeability that is responsive to several classical therapies for HAE, including kallikrein inhibitors. So in this setting, just showing you that we generated mice that had normal C1 inhibitor, heterozygous deficiency, or complete deficiency for C1 inhibitor, and that's reflected here in the plasma concentrations of C1 inhibitor antigen, and here quantified, showing a stepwise reduction in plasma levels of C1 inhibitor, and that this corresponds to significantly increased levels of cleaved high molecular weight kininogen, which is an in vivo marker of bradykinin generation. So you can see here a stepwise increase in the cleaved high molecular weight kininogen as you lose C1 inhibitor. And importantly, the C1 inhibitor deficient mouse model also showed us that mice completely deficient for C1 inhibitor have significantly increased circulating levels of markers of activation of coagulation, including the prothrombin fragments and thrombin-antithrombin complexes, here reiterating the procoagulant phenotype of this mouse model, and that the potential for thrombin generation in the plasma and whole blood of these mice was significantly enhanced. Here you can see that the blue bar indicating the mice completely deficient for C1 inhibitor is significantly higher and left shifted compared to the wild type control, again supporting a procoagulant state. We then looked at the impact of C1 inhibitor deficiency on thrombosis in mice. Here I'm first showing you data on a mouse model of venous thrombosis, the inferior vena cava stenosis model. And what I'd like you to appreciate from this is that on loss of C1 inhibitor in these mice, thrombus weight was significantly enhanced compared to wild type controls, again supporting an increased burden of venous thrombosis in mice deficient for C1 inhibitor. And what was interesting to us is when we then conducted a preclinical model of arterial thromboembolism, the carotid artery ferric chloride model, there was no clear apparent difference in the rate of occlusion of the carotid artery in these mice, suggesting that the phenotype may be specific to the venous bed and models of venous thrombosis. We then sought to ask the question of, well, we have this phenotype, can we rescue it with therapies that are known to be active for managing swelling in patients with HAE? So the first experiment that we did was to take whole blood from C1 inhibitor deficient mice and reconstitute it with either vehicle control or plasma-derived human C1 inhibitor, and then assess thrombin generation as a marker of coagulation. And here you can see in the red bars, with increasing concentrations of plasma-derived C1 inhibitor, a decrease in thrombin generation and a rightwards shift indicating suppressed thrombin generation that at about a dose of 0.48 mg per mil returns thrombin generation to around what we see for wild type mice, suggesting that this can normalize the procoagulant phenotype associated with C1 inhibitor deficiency. We've also looked at this in the setting of venous thrombosis, here treating C1 inhibitor deficient mice with plasma-derived C1 inhibitor, inducing thrombosis and looking at the severity of thrombosis in this mouse model. And here again, we see that treatment of mice with plasma-derived C1 inhibitor significantly reduces thrombus weight, with a trend towards reducing the incidence of thrombus formation as well. Again, supporting that we can modify the risk of venous thromboembolism, at least in the mouse model, by using standard treatments such as plasma-derived C1 inhibitor. And a question that we've been asked and is very related to our topic is, well, what drives this enhanced coagulation in C1 inhibitor deficient mice? And might that give us some insights into the apparent procoagulant phenotype in humans? So to do this, we've used C1 inhibitor deficient mice and treated them with a variety of inhibitors. We initially hypothesized that blocking factor 12A would suppress downward generation of thrombin. We treated mice with a knockdown approach to suppress factor 12 zymogen production, and were surprised to find that this had no impact on the baseline levels of markers of activation of coagulation in the mice. Similarly, when we knocked down factor 11 further down in the coagulation cascade, this also had no impact on markers of activation of coagulation. However, what was very intriguing to us is when we used a kallikrein inhibitor, this is the chemical name for avoralstat, this was able to significantly reduce the plasma levels of TAP, suggesting that kallikrein plays an important role in this phenotype. And this led us to reconfigure our hypothesis, thinking that maybe there's a vascular permeability mechanism. And so here, when we treated mice with a bradykinin receptor inhibitor, we found that this also suppressed this procoagulant phenotype. And also when we blocked tissue factor, which would be downstream in our proposed mechanism with an antibody, similarly, this reduced plasma levels of thrombin-antithrombin complexes. And this suggests, at least in the preclinical setting, that there's this interesting mechanism by which excessive kallikrein may lead to thrombin generation through a vascular permeability route mediated by liberation of bradykinin, activation of the bradykinin receptors, exposure of subendothelial tissue factor, and activation of the coagulation system thereon. And so, in conclusion, patients with HAE have evidence of a systemic procoagulant state. Several data sets demonstrate an association between C1 inhibitor deficiency associated HAE and an increased risk of venous thromboembolism. C1 inhibitor deficient mice model the procoagulant and prothrombotic state associated with HAE, and this is correctable by interventions such as C1 inhibitor replacement. And the procoagulant phenotype that we observed in C1 inhibitor deficient mice appears to be driven by a novel vascular permeability dependent mechanism. And obviously more work is needed to further understand both the human phenotype and the underlying mechanisms. And I'd like to leave you with a few outstanding questions. These include, does the relative risk of VTE depend on either disease or deficiency severity? What's the impact of long-term prophylaxis on VTE risk? And does this association extend to patients with HAE with normal C1 inhibitor? And with that, I'd like to finish by thanking all of the group that have contributed to this work, particularly my collaborators in the HAE space, Dr. Henrietta Farkas and Dr. Linda Sundler Björkman, and thank you for your attention.
Thank you very much, Stephen. So there are some questions, and we only have a few minutes for this. So, Stephen, D-dimer, the role of D-dimer in VTE and HAE, how could you explain this?
Yes, so D-dimer in the setting of VTE is often used as a positive predictive marker. So patients come in with suspected VTE. If they have a high D-dimer, that gives a high pretest, a high probability that the patient does indeed have a venous thromboembolic event. It's a well-used clinical laboratory assay that is a bit difficult to interpret from a pure coagulation standpoint, as it integrates both the activation of coagulation and activation of the fibrinolysis system, but it is used clinically in the setting of VTE.
All right. And last question, well-controlled and uncontrolled HAE disease. Does this impact coagulation risk? We saw some data on C1 inhibitor replacement that this could be protective.
Yes, absolutely. And that's something that we're looking into at the moment through additional epidemiological studies to separate patients who are receiving consistent long-term prophylaxis and look at whether that might modify their VTE risk. But that's not something we have any insights on just yet, but hopefully be able to share about soon.
All right. Thank you very much for this brilliant talks. And now it's already time to come to the end to this webinar series 9. So don't forget to complete the feedback form to receive the CME point in the end. You can access this here via this QR code on the left-hand side. It was my pleasure to have you all as faculty for this fantastic talks. Many people joined live online, but as you know, this is recorded, so you can watch it again afterwards. So there's the next appointment, as I said, dealing with advancing treatment options in HAE, September the 24th. And yeah, stay connected with us via social media and websites. And there's also the option to receive the newsletter. And last but not least, this is really a warm thank you to the Angioedema Centers of Excellence and Reference Network, ACARE, who initiated this fantastic webinar series. And this wouldn't be possible with help and support by our partners, which is Pharvaris, Calvista, and Enthelia Therapeutics. Thank you very much for joining. Thank you very much for being here with us. I wish you all a great day wherever you are. Thank you very much. Bye-bye.